Welcome all for this special session, Anti-Racism in Nursing Education and the Workforce, Leading Change. I'm Angela Amar, the Dean of the School of Nursing at UNLV, and I'm pleased to be joined in this conversation by Dr. Garrett Chan, CEO and President of HealthImpact, and Dr. Wallena Gould, founder and CEO of Diversity Nursing Education Mentorship Program. We're living through a period of monumental change and monumental difference. The pandemic and the shift to virtual work and education, coupled with continued calls for disruption of the racial injustice and health inequity, demands that leaders respond to structural racism in our institutions. Strong leadership and bold strategies are needed to ensure that our systems are anti-racist. Racial injustice is not a new problem. Structural racism is not something we choose to practice. Rather, public policies, institutional practices, cultural representations, and other norms work in various and often reinforcing ways to perpetuate group inequality. This often allows some type of advantage for some and corresponding disadvantages that people of color endure and adapt to. Just like our society, nursing has long been dealing with racial inequity and increasing our diversity. And within our institutions, we have policies and practices that intentionally or not produce outcomes that chronically favor or put a racial group at a disadvantage. So what now? What is the bold leadership needed? Statements have been written and posted, diversity committees and officers have been named, initiatives proposed. The challenge going forward is to live up to the promises and proposals. Our two fantastic speakers are going to address the structural and institutional barriers faced by our nursing workforce. As you listen, I'm proposing that you, as leaders, consider two important factors as you think about how to address these issues in your institution: accountability and investment. Both are needed to address institutional racism at a systems level. The first area is investment. The things that are important to us are invested in. We have associate deans for research in schools because we value research. We have QI professionals because we value improvement, reducing errors, and quality care. If diversity matters, we've got to commit resources in the form of money, human capital, and infrastructure. Just as every aspect of our strategic plan is resources, diversity has to have a financial commitment if we're aiming to change it. Is there involvement from higher level leadership? Are the positions adequately funded? Is the effort commensurate with the work required? Is there a budget for funding activities? We often have a volunteer committee who holds activities with punch and cookies. Where's the financial commitment? Is there a commitment for training, for time, for resources? If the area isn't clearly elucidated in our strategic plan, as often we say diversity is threaded throughout and isn't as clearly stated, then it won't also have a clear line for budget. This is important, we've got to invest in it. The second area is accountability, and it's an area that we often fall short in. Do our department chairs and deans, are they held accountable for diversity metrics? Are there consequences for not having diversity hires or a diverse applicant pool? A rich and diverse applicant pool lets cream rise to the top, and that's key. Often with our diversity events, attendance or participation is optional, and the choir comes. If this value is important for us, then we have to hold everyone accountable and mandate the activities. Do our course and employee evaluation tools have items related to diversity? If not, then we need to include those. We measure the things that we value. What happens if a faculty doesn't get a good evaluation on diversity? What do we do? How seriously do we take it? What's the plan? Accountability is often the piece that's missing in the implementation of our diversity initiatives. Overall, do we collect diversity metrics? What do we do with this information? Without accountability and strong metrics, we won't be working towards progress or changing our climate. So in closing, close with the reminder that diversity ignites innovation, it ensures belonging, it's required for excellence, and it moves us toward a preferred future for nursing. Thank you.
Thank you, Dr. Amar, and I want to thank the Academy for bringing this very important topic forward as a focus for discussion. Today, I'm going to be talking about the social determinants of health and education experienced by nursing students and new graduates. HealthImpact is the Nursing Workforce and Policy Center for California. And our vision is to help create a highly skilled healthcare workforce to optimize health through innovation, interprofessional leadership, and nursing excellence. Our mission is to shape healthcare through workforce strategy, convening stakeholders, and policy advocacy. Last year, we did a survey of newly licensed RNs in California who were licensed between September 2018 to August 2019. We invited over 12,000 newly licensed nurses to participate in our online survey. We did not collect any personal identification information, and we received close to 3,000 responses at a 24% response rate. We did find that about 75% of the respondents practiced in acute care, and about a quarter of the respondents worked in community care settings, and about half participated in new graduate transition to practice programs. When we looked at the race and ethnicity profile of the respondents, we found that about 23% were Latinx Hispanic, about 12.8% were Asian, 13% Hawaiian Pacific Islander, about 5% African American, and about 6% were other or mixed reported race. So we did have a diverse group of respondents that mirrors closely our workforce population demographics. So we asked about social determinants of health, the basic needs, and one of the questions was about housing. And we found that respondents reported while they were in school, they did not have a steady place to live, or they were worried about losing their housing, and that equaled about 21%. When they were working in the workforce, we found that that decreased to about 11%. We also looked at other basic needs of the social determinants of health, while in school as well as now, and found that about 33% of students had clothing issues, 31% had food insecurity, 30% had utility insecurity, and 30% had transportation challenges. That luckily decreased when they were in the workforce. We also wanted to understand commute times and the challenges that they had both while they were in school as well as in the workforce. And we found that the shortest one-way average, about 9% had greater than 60 minutes trying to get to and from their clinical placements. And then the longest average equaled about over 60 minutes equaled about 36%. While they were in the workplace, we found that the 13% of the respondents had one-way commutes of greater than 60 minutes, which is in some ways concerning for the physical and mental health of the workforce, because if the nurses are working in acute care, oftentimes they work 12-hour shifts, and so now we're adding an additional hour to an hour and a half on both sides of that workday. We also wanted to understand the financial status of these newly licensed RNs, and we found that about 54% of the respondents reported that they came from a low socioeconomic status background. We also were interested in understanding funding sources for education and found that 61% of the respondents use their own savings or use their own income to pay for school, and about 31% use a personal credit card, which is in some ways concerning because we know that they have high annual percentage rates. We looked at student debt at the time that they graduated, And we found that the median was 29% and the mean was 42%, with a maximum of $200,000 of debt. And we found that almost 30% of the newly licensed nurses had some concern or were very concerned about their confidence in paying back their student loans or educational debt. We also wanted to understand their perception of their overall health status, both while, again, in school as well as now, and the level of stress reported. So we found that about 12% reported that their health was quite poor in school, and that improved, fortunately, to about 4% while they were in the workforce. The level of stress we found for school was either quite or very much at 79%. And well, now it decreased to about 40%. Still high numbers of stress, both while they were in school and in the workforce. We wanted to understand mental health, so feeling down, depressed, or hopelessness. We found that in school, about 61% of the respondents had several days to nearly every day of feeling down, depressed, or hopeless. That decreased while they were in the workforce to 46%, but still a very high percentage and very concerning. Feeling lonely or isolated while they were in school, we found that approximately 70% had sometimes, often, or always feelings of loneliness or isolation. That did decrease while they were in the workforce to 51%, but again, over half of our workforce, or the respondents, felt lonely or isolated, sometimes, often, or always. We studied experience of physical harm or threat. So in the domain of being physically hurt, we wanted to understand the frequency. So from personal friends or family, we found that there were about 5% of respondents were physically hurt by personal family or friends while they were in the nursing program, or being physically hurt in the nursing program. It was about 4%, and in the work environment, again, it's about 4%. Being threatened with harm, sometimes, often, or frequently, by personal family or friends, we found that it was, again, about 5%. In the nursing program, about 2%, and in the work environment, about 5%. The last domain that we wanted to look at was around bias or discrimination. And so, again, in school, we found that racial discrimination or bias was experienced sometimes, often, or always at 18%. When they were in the workforce, we found that the number was 15%. For ethnicity, we found, again, in school that it was 17% that they experienced bias discrimination for ethnicity, and in the workforce, it showed that it's about 15%. And national origin, also, we found that it's about 12%, and in the workforce, 9%. Sexual orientation or gender identity, in school, the respondents reported that about 8% was sometimes, often, or always, versus now 7%. For religion, we found that the numbers were 6%, compared with in the workforce at 4%. And in disability, we found that the rate was 3%, and in the workforce, 1%. So now we have all these data, and how are we going to think about strategies, potential policy implications and initiatives to Dr. Amar's call for action? Some considerations for leading change are to integrate disciplines and community agencies that exist outside of nursing into our leadership teams. We know that scholars in different aspects of society can help us understand how to improve and create accountable organizations. So scholars in the social sciences, the arts and humanities, community-based service agencies, business groups, workforce agencies, and public health all have different perspectives and can help us understand how to make meaningful change, how to consider which initiatives we would want to invest in, and how to create accountabilities in these areas. In addition, we need to think about thoughtful and evidence-based interventions that are integrated into our administration and operations, our policies, the curricula, transition to practice programs, student services, and HR services to address these social determinants of health and education, bias, discrimination, and equity that's felt as a result of understanding the results of the survey. So I want to thank the Academy again, and you as the participants for the attention to diversity, equity, and inclusion. And for more information, you can always go to our website to download the full report.
Thank you, Dr. Amar. I am thrilled to have this space to bring a unique perspective from a nurse anesthetist and a Black woman's point of view on this timely subject with hopes of dialogue for change. But before I start, I would like to share a short quote from Marian Wright Edelman. She said, "You can't be what you can't see." Honestly, at the end of this discussion, I'm hoping you see me. So how do you address structural racism in healthcare and actively engage in moving towards an anti-racism policies and initiatives? First, you have to acknowledge that it's a broken system, and you have to dismantle that existing system that we are currently challenging today. Let's be clear. First, we must identify the prevailing structural barriers that historically denied seats to communities of color, whether they were student cohorts or faculty. But we need to at least acknowledge that we have a broken system. Second, we must hold accountable the leadership to take actionable steps. But most importantly, for the first time, accountability meaning having a reporting system with anonymous incidents that negatively impact communities of color, whether they're nursing students or graduate nursing students. Third, we need to build new relationships to transform into an anti-racist healthcare system and those who are responsible to train them. As a CRNA and the first one of color inducted into the Academy in 2015, which was just a short while ago, I want to talk about the difficult climb for prospective applicants of color for inclusion in schools of nursing. I want to talk about the difficult climb for nurses of color to gain admittance into nurse anesthesia programs. I want to talk about the difficult climb to become a nurse anesthesia faculty member, and also chief CRNAs and other CRNA positions. Let's first discuss the issue of identifying the structural barriers set forth in undergraduate programs. I was labeled, and this was over 25 years ago, I was labeled a non-traditional student, admitted to an undergraduate program. My intention was to apply for the School of Nursing, and I could not do that. Why? Because at the age of 19, I was a single mother on welfare. I was recently homeless for 3 months. And during that time, I had to find housing. And after I found housing, I received what they call Section 8 housing. 3 months later after that, I enrolled in a 4-year university. But I couldn't apply to that program, to the School of Nursing. Even though I was eligible for significant financial aid, which, by the way, the policies were set forth, and the academy is policy driven, and I need the academy to understand that there are certain policies that are already set for people who were like me to actually go to a college or a university, but I will outline exactly how that was impossible to do. My only reliable form of transportation at that time was public transportation. Think about this. Even though policies were set for public housing, the policy that was set was the Section 8, which was part of the Housing Act in 1974, in order for me to have an apartment. And it was designed for low-income tenants. The policy set forth for me to receive assistance, state public assistance, was by partisan support with aid to dependent families at the state level. So I could receive my $273 a month, $114 worth of food stamps. So that made me eligible for financial aid, which, by the way, which was by bipartisan support, such as the Pell Grant that was created by the Higher Education Act of 1965. So the only piece of that puzzle that did not fit was at the institutional academic level. So I couldn't even apply to the School of Nursing due to the barriers that were already set in place for someone who looked like me, who was poor, that lived in that community, that wanted to become a nurse, for two reasons. Because I had the lack of transportation and the heavy reliance on standardized tests called the SAT, a test that I know in high school I did not perform well in. So 1 year after graduating with a Bachelor of Science degree in accounting and working on Park Avenue, New York City as an auditor, I returned back to college, but this time in a non-traditional route. I went for my associate degree in nursing. Why did I do that? Well, at that time, during that time, after that 1 year, I purchased my own car, and I was able to apply to a program that did not rely on an SAT exam, even though I graduated from that School of Nursing, took the same boards as someone that went to the BSN program. So let's now move on to 8 years later. 8 years, I had to navigate this on my own to try to figure out how I was going to get into nurse anesthesia. I worked 8 years as an RN. Yes, 8 years to navigate a system that did not actively recruit me. They did not, nor ask me to apply. So I had to find all this information out on my own. So I'm going to move forward now to the graduate level and how to dismantle that existing system as we know it. Because under that system, I was almost not able to even become a nurse anesthetist. So I'm going to talk about, again, the institutional barriers that are already set. At the graduate level, there is the systematic reliance on standardized tests for admission consideration. Although there are a few programs that are stepping away from that, there are many that still have this test. So I'm going to tell you, and I'm going to say this out loud, no, the GRE is not a predictor of success. I know this to be true. So what I'm saying is, instead of using the GRE, use more of a holistic review process by graduating graduate nursing programs. Include the further de-emphasis of standardized testing, such as the GRE. So why do I share that story? Because I received a conditional acceptance for the nurse anesthesia program. I had to prove myself by taking 2 other graduate courses, at least get a B, and then get the full acceptance. Well, I ended up taking 12 to, I believe, 15 credits, received all A's before I started the nurse anesthesia program, completed that program, and passed the boards on the first attempt. So what did that GRE, how was that a predictor of success? If I did not do well on that test, but the outcome was positive for the nurse anesthesia program that I had applied to. I want to share with you another story about the GREs, how it impacted nurse anesthesia students of color. I recall I did a presentation for a state nurse anesthesia association about diversifying the profession. And on that one slide, there were 6 nurse anesthesia programs that accepted the GRE exam for consideration into the program. And there were 6 other programs that did not. This was in the Northeast region of the country. And the ones that did accept the GRE exam had the least number of diverse cohorts. The ones that did not accept the GRE exam have the most diverse cohorts in those programs. And guess what? Both groups, those nurse anesthesia students were able to still pass the boards on the first attempt. Again, what did that GRE predict in that instance? So now I'm going to move on to the workforce diversity in nursing. Let's be honest, workforce diversity is not a priority. Absent in nurse anesthesia programs today are faculty of color that look like me. Absent in hospitals today are chief CRNAs that look like me. So just to give you a background of what the nurse anesthesia programs are like across this country, I just want to share with you, there are 124 nurse anesthesia programs in this country. Of that 124, 116 programs are housed in what they call predominantly white institutions. Of that 124 nurse anesthesia programs, 8 are housed in Hispanic serving institutions, but there are none housed in HBCUs, even though half the Black CRNAs that graduate from these nurse anesthesia programs came from HBCUs. So to demonstrate the acuity of this problem and the state of faculty, the lack of faculty of color, I want to share with you just in the Northeast region, because that's where I'm from, in the states of New Jersey, New York, Pennsylvania, Rhode Island, Connecticut, Maine, and Massachusetts, there's approximately 30 nurse anesthesia programs. There's only one full-time African-American nurse anesthesia faculty in that region alone. In that region, there lives the most diverse, condensed population that we're taking care of. And I think at this time, this data cannot be denied or ignored anymore. So we need to intentionally hire nursing faculty of color at the undergraduate and graduate nurse anesthesia programs. And this is very important because the thing is that I'm not talking about performative hires either. I'm talking about not just hiring that lone faculty of color where you're going to assume that diversity tax for that whole institution. I'm talking about hiring CRNAs with an S of color in the nurse anesthesia programs to teach in front of the class. So how do you lead change? By including racism. You have to collect that data. And I think this is the first time that we need to, when I say we, I'm talking about institutions, colleges and universities, particularly schools of nursing, need to support institutional systems for anonymous reporting of incidents that negatively impact individuals from minority or underrepresented groups. Aggregate that anonymous data for these systems so that we can analyze it, identify it, and address the systemic racism that's actually taking place. For instance, microaggressions, examine the racial biases, the discrimination that's occurring. So this is very important. How do you lead change? By addressing anti-racism in healthcare. Well, you have to create and form new relationships with nonprofit organizations already doing the work. Fund those necessary established organizations who formed relationships with community partners to advance this initiative. In addition, collaborate with HBCUs and Hispanic serving institutions, along with nursing programs where students are eligible for grants such as what I received as TAG and Pell grants, so that they will be exposed to advanced practice nursing, right? So nursing students of color need to see us as CRNAs when we go visit their schools. When I say we, and I'm talking about my own diversity nurse anesthesia program, we have a tour to go to specifically HBCUs, Hispanic Serving Institutions, schools of nursing. But it's not just the fact that they are seeing us as CRNAs, and we're going there to talk to them about going into the profession and doing airway workshop. I'm talking about having a CRNA such as myself as a fellow, going in front of them to tell them that, yes, you can become a CRNA, and yes, you can become a fellow. As a CRNA of color, it's important that the nursing students see us. They need to engage with us so that we can teach them and guide them along the way. We also need to form collaborative relationships with larger institutions and maybe even outside of the academia. For instance, in California, for my program, the Diversity Nurse Anesthesia Mentorship Program, every year for the past 8 years, we've had a Diversity CRNA event at Samuel Merritt University. You invite 4 nurse anesthesia programs from California. And we talk to nurses of color that are interested in going into nurse anesthesia. Most of them, just like me, were first generation. And we give them all of the information about the rigors of the program, the clinical expectations, how to balance family. We talk about the doctorate programs, what the expectation is. We talk to them about how to become a strong applicant. We have that second day of the airway workshop. So, all right, so we have all these nurses from across the country that come to these types of events, particularly in California. Just one event out of 4 that we do every year. And from that event, those students afterwards will apply to those programs, get accepted into the programs, be trained from those programs, pass the boards, and they end up working in deliver anesthesia at Kaiser Permanente Health System, Sutter Health System in California, UCLA Health System, Stanford Medical Center Health Systems. That's what I'm talking about by having a collaborative relationship with those large institutions, so that because we actually feed the programs to go in there and for nurses to go and actually be successful in the program, but they're actually working in those communities in that state. That's what I'm talking about. So we believe that I believe that the implementation of these proposed areas of concern will begin to dismantle the current racist underpinnings within our own educational system and help to improve treatment and experiences of people of color in nursing. My final thoughts is that you have to frame the right question to go forward for an anti-racist policies and initiatives. The question should not be posed to me about how I'm going to dismantle this system, because right now, all I'm doing is just providing the landscape on the truth of the inequities set in our broken system, where there's tremendous barriers. But what I would rather pose a question, the better question in my Toni Morrison voice is that, what are you going to do about it? Take me out of it. Thank you.
Wow, this was very impressive. I certainly learned a lot from listening to both of you and thinking about your experiences. So thank you for sharing those very powerful words. One thing that really struck me as I listened to you guys is this whole notion of this not being a new problem. This is a problem that nursing has been experiencing, and the things that we've tried in the past really haven't worked. And so both of you sort of came from a disruptive innovation place in terms of thinking differently about this. Garrett, you spoke to having people from outside of nursing, which I love, because I think as nurses we tend to just focus in on nursing. And Lena, you spoke about partnering with systems. So I'd love to hear you say more about this idea of how we invite other people outside of nursing into this conversation to help us really change the way we address or attempt to address this problem. So Garrett, would you start?
Sure, thank you. And I also want to say, Lena, I very much appreciated your powerful story, so thank you for sharing. One of the things that I have thought about is that there is a lot of experience out in the world, and in nursing, there has been budding efforts in various places, but not uniformly adopted. And so we need to look to experts outside. And one of the things that again, listening to Lena's presentation reminds me that we need to bring the humanity back into this. Well, yes, there are scientific, advances and understandings that we need to make, but we can't lose the person or the people who are experiencing discrimination, racism, bias. And so by helping create a humanistic environment, we should look to others in the social sciences like sociology, but also in art departments, thinking about the visual arts and the written arts, and thinking how can we weave that in so that we can always keep the person at the center.
And thank you, and I appreciated your presentation too. As far as partnering with outside organizations, it's very important that we partner and continue a relationship with, as I stated in my own story, the associate degree nursing programs, because I had a bachelor's degree in another discipline, and I was able to go right into that type of school of nursing to get my degree. There are other nurses of color who can't commit that time frame of 4 to 5 years to finish a BSN. So it's very important that the schools of nursing develop a relationship with the associate degree nursing programs within that community, because it's very important. And even if that means you have someone that was a graduate from that program, that is important too. If you have a graduate from that program that look like me, that from a BSN program, and there's an associate degree program in that community, it is very important. It's important that they become the ambassadors to that school, and also they're also lifting and helping someone else that may not have this information. And for many of them, just like I said, I am first generation. So it's very important. Another partnership is to make sure that you have partnerships with the HBCUs and the Hispanic Serving Institutions, schools of nursing, and also with programs, predominantly white institutions, but the nursing students of color, especially in those programs, because sometimes there may be just one nursing student of color in that program that don't even know about the other opportunities out here, particularly for males, Black men, Hispanic men especially, that are in nurse anesthesia programs. So we need to partner with them and make sure that we have those leaders, we have those advanced practice nurses in front of them in those institutions, so that they can also be mentored. So it's very, very important that we do that. And also with health systems, where ultimately nurses and nurse-nesses will be hired at. So it's important that we bridge those relationships in order to advance going forward.
Thank you both for those responses. Now let's move to the live portion and Q&A from our audience. Wow, thanks for those awesome and inspiring remarks. I know that everybody's buzz in the chat with lots of positive feedback and feeling very good about this. So before we move to the questions that people have sent in, I'd like it if you guys sort of talk after hearing each other's remarks, made any other statements that you'd like to make. So we'll start with you, Garrett.
Thanks, Angela. There are two things that I have been thinking about. One is the concept that one size fits none. We need to create actions and interventions by listening to our constituents and their specific needs. Dr. Linda Burns-Bolton talks about creating spaces for calling the circle, or bringing people together for communication, mutual support, teamwork, and social change. And that.
So Dr. Gould, do you want to chime in? And then when we get him back, we'll let him finish.
Sure. I would like to start out with saying that building pipeline initiatives within each institution should be the priority. And when I say that, I'm talking about making sure you cannot start increasing diversity in graduate nurse anesthesia programs if you don't address what's going on in undergrad, right? So that also includes the fact that the structural barriers that I was talking about earlier, with those two standardized tests with the SATs for undergrad and for the GREs for graduate school, I think that should be re-examined. Because like I said before, that if you take away that exam, you have more diverse cohorts, and they still do well on the boards eventually, right? So, and also, if there's pipeline issues when it comes to nurses who are interested in going back to school for their doctorate, most definitely the options should be included with the not just the DNP, DNAP programs, but also with PhD. So I think it's very, very important that institutions understand that this is a pipeline initiative that should be moving forward.
Thank you. And glad to have you back, Dr. Chan. Do you want to finish up?
Sorry, I just wanted to say that Dr. Linda Burns-Bolton talks about creating spaces for calling the circle, or bringing people together for communication, mutual support, teamwork, and social change. And so it's going back to my previous point about one size fits none. We have to listen to our constituents and understand what their specific needs are. And then the other thought that I had was that we need to integrate the arts and humanities with our science to create a cultural movement. I really loved how Kevin Sowers in the keynote today sang at the end, because we need to address the psycho-emotional aspects of anti-racism and change. And so let's not forget the arts and humanities and how important a role they play as we move forward in this work.
Thank you. So while you're up, Dr. Chan, people are very excited about the work that you've done and are very interested in what the future holds and your plans for any replication or expansion of the study.
Thank you. We are planning to replicate this study. One of the limitations of our study was that we studied newly licensed RNs. So what that means is that the respondents had to have graduated from their nursing program and also passed the NCLEX. And we know that the social determinants of health and education and challenges that are experienced by nursing students can create significant burdens and delay or even require a student to make a choice whether they should continue or can continue towards graduation or not. So our next phase will be to study nursing students while they're in nursing school to see if we have higher rates or lower rates of bias, discrimination, and challenges with social determinants of health and education.
Wow, that sounds pretty meaningful. Glad to hear that. Lena, people, as I said, lots of great comments about your talk. One question that people are particularly interested in is can you talk a bit about what resources would be available to schools to guide the acceptance of diverse students into their programs? And I think a big part of this question is, how do people knowingly target diverse and minority prospective students without introducing bias?
Well, what I would like to first say, when they're talking about schools, I'm not sure if they're talking about high schools or nursing schools, but for both, students are primarily, they're motivated, but they don't have the proper direction, right? I mean, when I was in high school, I didn't know about nurse anesthesia at all. And it wasn't until after I graduated from School of Nursing, that's when I found out about nurse anesthesia. So it's very important that the students are informed about the profession, but that may include, and it should include, that CRNAs in particular are coming to these institutions where they're being invited to speak, they're being invited to be lecturers, they're being invited to come on as an adjunct faculty because full-time faculty, because that's the only way nursing students are going to find out about other disciplines that are out here, instead of trying to navigate it on their own. Now, certainly when it comes to the students, once they graduate from the School of Nursing, they are introduced to CRNAs, particularly of color. The thing is that their network has now expanded. I mean, I was a first-generation college graduate. For many of them, they are too. So the thing is that you want to make sure that their network has expanded, that they're fully informed on the direction that they need to go on to be successful. And that includes, and especially for nurses of color that are interested in going into nurse anesthesia, we offer and we make sure that we have, as a free service, for anyone that want to prepare for their mock interviews, we'll do that too. And we'll also look at and review and critique your personal statement as well before you submit, because that's important, because even that, just if someone wasn't reviewing that may be an indicator where, right before you can even be considered for a program, you may not even be considered because of something that was said in the personal statement, or you didn't do well during your mock interview. Now, certainly when it comes to the actual interviews, the one thing that we cannot control is the fact that, yes, we have faculty that are interviewing individuals, but hopefully and prayerfully that in the near future, that will change, where it's more of a diverse faculty that's making sure that they are also being interviewed. They're interviewing diverse communities of color that are out here too.
Thank you. So I have a question for both of you. So I'll let Garrett go first and then Lena. And this one is a really useful question. How can we begin to change these systems and structures that are in place to include our prospective biracial, indigenous, people of color students at all levels of education, undergraduate and graduate? So it's kind of dismantling those systems. So Garrett?
Yeah. Thank you, Angela. As I mentioned before, again, I think that one size fits none, and we have to open up these, call a circle for students to raise their voice around what are the big challenges that they're facing. So I'm from California, which is a very large state. I kind of joke that you can fit 21 New Jerseys into one California. And so the challenges of perhaps Black, Indigenous, Latinx, Hispanic students, and even nurses might experience in a rural setting may be very different from the same demographic population in an urban setting. And so as we continue to think through dismantling the structural bias and discrimination that exists, we need to ask very targeted questions around what are the challenges and what are the things that people need in order for them to be successful in their work as well as in nursing school. And so as we think about these strategies as leaders, it's important to also consider bringing in, as I mentioned before, colleagues from social sciences like anthropology, sociology, the arts and humanities, to open up that space where people can feel safe to have these conversations. It's also very helpful to speak with somebody from a shared background. And so as you're creating these circles to have the conversations, think about the structure of the makeup of the people who will be facilitating those circles.
Thank you. Lena?
Yes, and I would like to respond by saying that it's about making sure that nursing students and nurses of color in particular have access to opportunities that are not out here, because sometimes that too is a barrier. What I mean by that is, in order to become a nurse in essence, you have to shadow a CRNA. And if you are a first-generation college graduate and may not have or know someone personally as a CRNA, then that's also going to hinder their chances of getting into a program. So I think schools of nursing should, either schools of nursing or other institutions should make it available so that if there's a graduate from that program that is from a diverse background, perhaps maybe they can come into that school and make sure that they are present every semester so that they can talk to the students. Again, be invited to the classroom, like Dr. Adriana Perez did for me at the University of Pennsylvania, because I know that there are other students that are out here that do not know who we are. And you have to open up spaces for those to make sure that they too can shadow CRNAs, even if that means, and sometimes that does mean, that you may have to leave your state, get on a flight, you may have to find someone else that will allow you to come in so you can shadow that CRNA so that you too can be just as competitive, just as the one that you work with at night. So it's very important that we make sure that we create opportunities of access so that those nursing students and nurses of color will be able to have that in order to advance. That's what I have to say about that.
No, thank you very much. And it leads me to my next question, and it fits with you bringing up Adriana, because I think she does a great job at this. How can students of color find mentors or examples? What are ways you suggest? And I would say that it's bigger than just ad-libbing on the question, that it's not just about providing students with those mentors and exemplars, but I think if you look at the majority of nursing faculty and workforce who tend to be primarily middle-age, middle-class, white women, how do we give everybody this opportunity to have this enrichment from learning from others? So we'll start with you, Garrett, and then Lena.
Those are great questions, and I want to echo Dr. Fields' comment in the last session, which is that we do have national ethnic minority nursing associations. And so my question is who's ever attended a local chapter or a national event held by any of those ethnic minority nursing associations? And so those are great places to start for faculty to connect and to understand and to learn from people who have a lived experience. Also for schools of nursing, perhaps do a call to alumni and create connections, because it can be quite lonely, right, as we continue to move through this world if we don't know anybody else. And so making a concerted effort to create the call the circle for individuals of shared backgrounds and experiences to network and meet each other are some examples that I would suggest.
Thank you, Garrett. Lena?
Yes, and I would like to respond by saying that the mentoring it's in our world, when it comes to diversity in the anesthesia district program, it's all about making sure that you're informed and inspired, but also your network of CRNAs and nurse anesthesia students across the country has increased. For example, if a student of color was accepted into a program, say, the Duke University Nurse Anesthesia Program or University of Miami Nurse Anesthesia Program, but they live in Texas or they live in Connecticut, what I would do, and if they were, say, for example, Puerto Rican, I would make sure that they are connected with a currently enrolled nurse anesthesia student that looked like them, or someone that graduated from that program that looked just like them. So now they are not only connected with a nurse anesthesia student that's in the program, but someone that they're from similar backgrounds, and that is important. And I think that the dynamics of the mentoring needs to change, and that also includes not just the ones that are getting into programs, but also those that are, once they graduate and then they're starting to look for positions. You know, if it's a CRNA, a nurse anesthesia student that's newly credentialed looking for a position and they live in New Jersey and they want to get a job in California, we already have networks where they can be introduced to someone else that's over there on the West Coast side, and they'll be able to make sure that they get those positions in those areas where they want to work at. That also includes mentoring faculty of color, so that if someone else that looks like me that is interested in going into a faculty position, there is a circle of faculty of color now in nurse anesthesia that we will get on the phone with them and talk to them about what the expectation is. We would, and it doesn't matter what program that that they're going into. So there's support for nurse anesthesia faculty, and also for those CRNAs who are interested in going into to those teaching positions, so that they know what to look out for and what the expectations are. So the mentoring paradigm right now, as we know it, should change in order to make sure that there's going to be some profound outcome as a result.
So thank you very much to our fabulous presenters and to all of you who chose to spend this part of the afternoon with us. We've learned a lot about the state of affairs for both our workforce as well as our students. And we've also had some conversation about systems level strategies for change. So I hope that you all stay for the next session, which is about elevating inclusivity and affecting change. And thanks again to our fabulous presenters.
Hello, I'm Kenya Beard, the Chair for Diversity and Inclusivity at the Academy. Our distinguished speakers and facilitators, thank you for your expertise, your openness, and willingness to share. And to our audience members, thank you for your presence and insightful questions. From the beginning of the pandemic, it was apparent to us in New York that COVID-19 was impacting racialized groups at disproportionately higher rates. As chair of the Academy's Diversity and Inclusivity Committee, I joined my colleagues at our April meeting to mourn our losses, express our frustrations, and to better understand the ways in which the deeply rooted racial injustices contribute to these inequities. When George Floyd was killed by police officers over Memorial Day weekend, shortly after the murder of Ahmaud Arbery in February and police shooting of Breonna Taylor in March, it seemed impossible and irrelevant for the committee to focus on anything besides the tenacious ways that racism presents in all aspects of our society. Throughout the summer, President Eileen Sullivan Marks released statements and a fan mail message calling on the fellowship to join together in collective reflection and action against racism within our organization. The D&I committee knew we needed to do more. We knew we needed to act in a forward-thinking and public way to begin the process for healing and change. The committee agreed that hosting this critical conversation was essential and would provide a platform where we could acknowledge the pain caused by structural racism, the normalization and legitimization of practices that advantage some while harming racialized groups, and to find solutions that will make a sustainable impact. As providers, false beliefs and assumptions can cause irrevocable damage to the individuals we pledge to do no harm to. As educators, we influence the next generation of caregivers. Therefore, it is our duty as nurses and leaders to process and understand what we learn today and use it not to shame or blame each other, rather to move forward in a way that allows us to come together to dismantle the structures that impede health equity within our individual organizations and throughout our collective systems. On behalf of the D&I committee, we are so incredibly grateful to the board, in particular, our board liaison, Dr. Deborah Barksdale, the INL, and the Robert Wood Johnson Foundation for their support in making this courageous discourse possible. I look forward to seeing the progress we make moving forward, and I'm sure that at a minimum, this event will serve as a catalyst for a more diverse, inclusive, equitable, and socially just academy. Thank you.
Hello, I'm Julie Fairman, and I'm honored to be the chair of the Institute for Nursing Leadership's Advisory Board. This has been an incredible program. I'd like to thank each of you and also the speakers and facilitators, as well as you, the engaged audience, who helped to make this INL critical conversation event successful and give us the foundation to have an impact in our work and our lives. As a historian of nursing, I have seen the long history of racism and unequal treatment in our health systems, our education and academic systems, and our health policy. It is my sincere hope that this critical conversation, our in-depth dialogues, and the upcoming reflection rooms will create the necessary call for each of us to put in the hard work, to change policies and practices that promote bias, and ultimately achieve equitable care in all entities. Before we break out into the reflection rooms moderated by members of the Diversity and Inclusivity Committee, as chair of the INL National Advisory Council, I would be remiss not to thank the co-chair of the INL, Jenny Chin Hansen, and our planning committee members, Dr. Bobby Berkowitz, chair, and Hussein Tahan, co-chair, as well as Kupiri Ackerman Barger, Guardia Bannister, Jackie Dunbar Jacob, Janie Heath, LaRon Nelson, and Adriana Perez. I would also like to thank my colleagues on the INL National Advisory Council and the Academy's Diversity and Inclusivity Committee members for their support, which helped to create such a dynamic program of impact. I must also thank the Robert Wood Johnson Foundation for their generous partnership and support of this crucial event. Finally, I would like to recognize and express appreciation to Karen Drinkard, our board liaison for the INL, and a longtime INL committee member and former co-chair. Now, please check into the reflection room session where we will engage in real time with each other to discuss the day's conversations and unpack their ramifications. This is a time to pause. Ask the questions that will continue and encourage us to think differently and help us build in all of our communities a culture of civility, diversity, inclusivity, and equity. Thank you again for joining us, and I look forward to the progress we can achieve together.